Hello and welcome to the latest edition of WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio-Menard. Minimally invasive robotic surgery has opened up a whole new world in accessing those hard-to-reach places. Today, we're talking about robotic head and neck surgery with Dr. Meghan Turner from the WVU Medicine Department of Otolaryngology. Welcome to Tuesday Talks, Dr. Turner.
Thank you very much for having me.
It's good to have you here. Now, we do encourage questions from our viewers, so feel free to post your robotic head and neck surgery questions in the comments section, and we'll try to answer them for you live. Okay, so let's start with the basics. First of all, Dr. Turner, how exactly does robotic surgery work?
Well, the Da Vinci robot is a new surgical tool. It's been around since the early 2000s. It was first used in cardiac surgery. And since that time, it's been expanded to be applied in multiple areas of medicine. We in head and neck surgery joined the game a little bit late, around 2009. And it is primarily used as a tool to operate on tumors of the head and the neck. And those are sometimes benign tumors, but most often those are cancers, early cancers of the larynx, meaning your voice box, and the oropharynx, which is the tonsil and the base of tongue.
Okay. So how does robotic surgery, how do you access those hard-to-reach places that, usually would take open surgery?
So robotic surgery uses the natural orifices, such as the mouth, the nose, or remote access incisions. That is, an incision may be placed in the hairline or in the cheek in order to reach areas that are small. So if I were to operate with my hands, my two hands, I wouldn't be able to get my hands to the back of your throat and do those fine, precise moves in order to take a cancer out without causing some major damage, or without having to use a large facial incision and then beyond that further get access around your jawbones by splitting the jawbones, say with mandibulotomy, which is a cut with a saw through the mandible and sort of splitting that open in order to get into the back of the tongue. Because you just can't see around those corners where these tumors live. And to access the voice box, similarly, we would be talking about actually opening the throat through the neck and connecting and being able to see inside. And so you can imagine that even with big incisions, there are areas you just don't see as well. And so with robotic surgery, and particularly the new version of the robot that we have at WVU, the single port robot, there is a flexible endoscopic camera that has a high definition 3D camera that you can insert through the mouth and be able to see deep down into the back of the throat where these tumors grow and operate without having to make such big incisions that change people's lives and the way they look.
Yeah, and I think it's important to clarify because I think some people think it's a robot doing the surgery, and it's not. This is more like, I guess, it's robotic-assisted surgery, and you're manipulating smaller tools that are smaller than your fingers or hands to get into these areas.
Correct. While I have, some would say dainty hands, these hands still can't fit into the back of your nose or throat. And so the robotic instruments are no bigger than my pinky finger. And the new robot actually allows me to place the camera and 3 instruments into the back of your throat, see what I need to see, and then gives me an extra arm to move things and manipulate them in the way that I wish to do so. Not to mention the fact that my hands have their own limitations in how much they can move. Say, 180 degrees, maybe 270 degrees, but with the robotic arms, there's actually 540 degrees full rotation in areas that I would not be able to make those movements, even sometimes with a big open incision. And so that high definition camera allows me to see things really with microscopic vision, just using a flexible endoscope.
So what are the most common conditions you treat with robotic head and neck surgery?
So the most common conditions are tonsil cancer, and that's true nationwide. That was the first explored use back in 2009 and proposed use. And it's a time-tested at this point, we have 10 years of data and research backing the results of robotics-assisted treatment of base of tongue cancers and tonsil cancers. And when I say base of tongue, I'm talking about lingual tonsils, and those are the tonsils that you can't see through the mouth. They're at the back of the tongue. And so that's the most common condition. Some patients who are smokers and have smoking-related cancers of the voice box are also lucky enough to come to us early and be candidates for robotic supraglottic laryngectomy or a robotic-assisted removal of their voice box tumor.
Wow.
That is a little bit more rare, again, because they have to be smaller and select tumors, but that is one of the tested applications. Additionally, there are tumors of the parapharyngeal space.
Which
These
is what?
are skull-based tumors. And
Okay.
if I were to point to the parapharyngeal space, it would be at a line that goes and intersects in between my two fingers,
Okay.
sort of at the back of your nose, very high up and lateral in your throat. And if you were to try to get to these, from the outside, you're talking about going deep up under the jaw,
Yeah.
and around the facial nerve. And it's very difficult to see, as you might imagine, through a big incision all the way up into these deep, dark places. But with the robot, you can go through the mouth and have the endoscope have you see all these things sort of close up and work easier.
So what are the most important benefits of robotic surgery?
For, I would say, most of patients, they would agree that the robot offers better functional and cosmetic outcomes than an open procedure for the same treatment.
So smaller scars, smaller incisions?
If a scar, if we're
Wow.
talking about the tumor itself. Not all patients, say in the case of a benign tumor involving the back of the throat, those patients may need no incision. It could be done completely through the mouth. And so there would be no external scar visible.
How about quicker recovery?
Indeed, yes. The stays are shorter. Every patient is a little bit different, but there is, as you could imagine with the pain, some trouble swallowing afterwards. And so it depends on how well we control that pain and make it tolerable until the patient is able to drink and eat. I have some patients that bounce back really quickly the third day. Others who are more sensitive to pain, which that is widely different patient to patient, may stay with us a week. And again, they're not having to have their jaw broken and all these other things. So by and large, these patients get out of the hospital faster than if we treated them with the old ways, that were used back in 1980, 1990.
And you mentioned earlier, that you do treat, cancers, removal of tumors. Can a patient avoid radiation and chemotherapy if they're, a good candidate for robotic head and neck surgery?
So when I have a patient come to the office and they ask me that question, my first response to them is, we have to do what's best for your tumor. And your tumor will will have information about your tumor with the pathology. And so I can never predict any one patient who's going to need radiation and chemotherapy, but they do have a shot. So about half of the patients who have robotic surgery will need radiation afterwards, and about a third of them will need chemotherapy. And this is dictated by the behavior of their cancer. If you have a bad behaving cancer that on pathology shows those really adverse features like extranodal extension, maybe perineural invasion, these are bad actors, and number one, I want my patients to survive.
Yeah.
We want them to live the rest of their life cured of their cancer. So patients need to sign up for doing what it takes.
Sure.
Some patients are lucky enough to have a cancer that's not acting badly, and
can avoid that.
For those, they can avoid that. And previously, their only option, in the last 20 years, we moved away from these big open procedures in favor of non-surgical treatments, chemo and radiation, which have a great success rate in treating these cancers, 80%, 85% if early. But then those patients were stuck with the long-term side effects of radiation to the head and neck. And radiation to the head and neck has toxicities that never get better, and there's no cure for. So those patients whose tumor is not acting badly, that does not demand radiation to get them cured, they get to avoid that, and then they get to avoid all that toxicity.
So those are the benefits. What would be the risks of robotic surgery?
So the risks of robotic surgery are no different than the risks of open surgery. As you can imagine, operating in the head and the neck, this is important real estate. There's a lot of important things here. We experience the world through our head and neck. We have our sight, our smell, our taste, lots of sensations important in all of the daily activities and in interacting with loved ones. So any function that is lost after head and neck surgery really impacts your life. And while every surgery that we do as head and neck cancer surgeons is not considered cosmetic surgery, we still go with the goal of giving you the best cosmetic and functional outcome that we can for every patient, because your head and your neck is who you are. It's your face. Right? So that being said, the risk, there's important nerves, important blood vessels. Any surgery of the head and neck comes with risk of bleeding, of change in the way that you swallow, of potential difficulty breathing afterwards with any of the swelling that you have. So those are no different for robotic surgery. I would just say that in the right patient, the swelling that you have and the dysfunction that you have are less, because you can preserve all of the structures that are possible to preserve. The only thing that we can't change is what your tumor has already affected. So we can never make you
can't reverse it.
We can't reverse the damage that the tumor has already done, but we can minimize the damage to other tissues nearby and nerves and blood vessels that are critical for your function, your swallowing, your talking.
So who's a good candidate then for robotic head and neck surgery? I imagine not everybody can.
I wish everyone was lucky enough. Early tumors, some large tumors, even late tumors, are still candidates, and it's actually extremely complex because it's all based on anatomy and what your tumor has already started to involve. So I will say that the earlier you get to us, the better. And there's no age or other factor. A lot of it is anatomy, and so it's really important to meet a surgeon to see if you're a candidate, because the physical exam really tells you who's a candidate and who isn't. And it's a complex decision with the surgeon and the patient. Patient has to be motivated and understand what they're going to go through. And some patients still may decide to go through chemo and radiation after hearing, what they're going to go through. It's painful to have surgery. You know?
Yeah,
And as
yeah.
you can imagine, in the head and the neck, swallowing is painful at the first, and you don't realize how many times you do it a day until you have surgery.
Yeah.
So every patient gets a very blunt and upfront description of what they're going to go through. And, you know, I always say it's important to think about the short term.
Mm-hmm.
Yes, there's going to be pain, but we're going to rehab you. And once you get through the pain and the initial acute phase of surgery, that first week is awful. The second week, you're still recovering. If you think about just regular tonsillectomy that you do for chronic tonsillitis in adults, that is one of the most painful operations that an ENT does.
You're making me hurt.
And it's no different than that. It's 2 weeks of misery. But after that, that's what we're shooting for, is you getting back to your life and functioning.
It's a long game.
Right.
Yeah.
And living your life in a way that's good and with the best possible functional and cosmetic outcome that I can give you.
Now, I don't want to understate your expertise or the expertise at the WVU Medicine Otolaryngology department. I know that you performed the first robotic skull-based surgery a couple years ago, and you have performed some first-in-the-world procedures. First in the world. That's so impressive to me. Can you talk about that a little bit?
Well, so what I would say is they were the first robotic procedures for that particular tumor, right, or that particular problem. Mm-hmm. So I basically have pioneered the development of robotic skull-based surgery for parapharyngeal space, for infratemporal fossa tumors, through the maxillary sinus. That surgery existed, though, before.
Okay.
It existed with endoscopic surgery, purely endoscopic surgery.
Okay, now let's establish what endoscopic surgery is and how that's different from robotic surgery.
Sure. So with endoscopic surgery, it's much like you may have heard of somebody having sinus surgery, where a rigid endoscope is put through a natural orifice, the nose or the mouth, and that camera is then used to perform surgery with endoscopic tools that are long, can move in and around the nose. Now, endoscopic surgery is, because it requires a rigid endoscope and long instruments, one of the downfalls of that is if one surgeon is operating, well, one hand is having to hold the camera, so then you become a one-handed surgeon. And a lot of endoscopic procedures, you require two surgeons, a two-surgeon surgical technique. One to be the active eyes for the surgeon, sort of keeping that scope clean, irrigating the field, suctioning blood if they can. And the other surgeon is responsible for dissecting the tumor. With the robot, so I did two separate fellowships, one in head and neck surgery and robotic surgery, one in endoscopic skull-based surgery, going through the nose to get tumors with our neurosurgical colleagues up in the brain. And a lot of those techniques required two surgeons. The perfect marriage of those two fellowships was really what brought on the use of the robot to do skull-based surgeries, because you can now use the robot to be a four-handed surgeon. One of the arms is the endoscope, one of the arms is for retraction and exposure, and then I still have two functional arms to manipulate the tumor and do the dissection and preserve those nerves. So I would just say that I am using a pre-existing tool to perform previously described procedures in a new way. So it's not like we're experimenting on patients,
no, I understand.
or anything like that. But I have developed the use of the robot to perform that surgery in a way that hasn't been done with the robot before. And first, that was tested out on cadavers, and then applied in the right patients.
So needless to say, we have the expertise here. You have the expertise, especially in
yes.
this particular
And
field.
we do endoscopic skull-based surgery weekly here at WVU as part of a team. And so those same techniques that are used every week for pituitary tumors still apply as I operate on, say, a parapharyngeal space tumor or something else through the maxillary sinus with the robot. It's just using a different tool in a new way.
It's all right here. You don't have to leave the state, right?
That
Close
is
to
true.
home. We like close to home. We did talk a little bit about tonsil cancer before, caused by HPV, and if you can just briefly talk about a little bit of how that's on the rise and how you treat that minimally invasively as well.
Oh, sure. So tonsil cancer, like I said, is one of the most common diseases treated with robotic head and neck surgery. It is the cancer that was sort of the first thing we tackled with robotic head and neck surgery. Tonsil cancer has become more common in the last 20 years. At this stage in the game, HPV-related tonsil cancer, that is tonsil cancer caused by the human papillomavirus, is more common than cervical cancer caused by the HPV virus.
Wow.
Now, in raw numbers, is that true? There are per year more HPV-related tonsil cancers than cervical cancers. Why? So it's because we've started many years ago, 20 years ago, we started vaccinating women and screening women for tonsil cancer or for cervical cancer at young ages. And so there's been a push to prevent cervical cancer through vaccination. And that became available in the 2000s with several vaccines that are out there. Gardasil is an example. And they go after multiple strains of human papillomavirus. That is not true and has not been true for tonsil cancer until very recently. And so now if you're watching television, you'll see advertisements that say, "Cancer not my child." And they're advertising for the HPV vaccine. And they are now targeting boys and girls in order to prevent HPV-related tonsil cancer down the line. Human papillomavirus is the same virus that causes warts, warts on fingers, warts on your knees when you're a kid. It causes other types of warts due to sexual contact. And, we are human beings, and it's the human papillomavirus, and human behavior, meaning sex, causes both tonsil cancer and cervical cancer.
Okay.
Some
Makes sense.
patients clear the virus and never get cancer, but 90%. Actually, I think the latest data was 85% by the age of 20. 85% of humans will have had HPV.
Wow.
And the unlucky few that don't clear the virus will develop cancer because it uses your cells, your tonsils, and the tissue around the cervix to spread itself.
Wow.
So.
Well, before we go here, because we've covered a lot of ground, what's the most important thing you want our viewers to know about robotic head and neck surgery?
It's available in West Virginia. It offers a shot at tailored treatment of your cancer in a way that allows you to have the best possible functional outcome. It allows some patients to avoid radiation and chemotherapy, which for the head and neck have really severe long-term side effects. While they're effective tools, the way that radiation affects the head and the neck 5, 10 years, 15 years after treatment, those things are irreversible. And because patients with HPV-related cancers are young, sometimes as young as 35.
Wow.
we don't want you surviving to suffer. We want you surviving to live a great quality of life. And so
Sure.
I would love to offer everyone robotic surgery who's a candidate, and you can get it here at WVU. You just have to seek it out. Not everyone will be a candidate, and not every patient will decide after hearing about it.
Sure.
But I think it's important to consider your options and get cancer treatment that's tailored to you.
Okay, great. Thank you so much, Dr. Turner. This is a lot of good information, a lot to think about, but just good to know that this is available here locally and we can stay close to home. Thank you.
Thank you
really.
for having me.
And that brings us to the end of this edition of Tuesday Talks. If you're looking for more information about robotic head and neck surgery, you can always visit wvumedicine.org/ENT. I'm Mary Ravazio Menard, and before I go, I want to tell you to watch next Tuesday because our topic will be kidney transplants on Tuesday Talks. That's March 8th. Thank you for joining us on behalf of Dr. Turner and all of us at WVU Medicine. Thank you for joining us, and have a great afternoon.